The question of birth defects and antiretroviral drugs is a difficult one to give a simple answer to. And the reason is that there is such limited data about the use of these drugs in pregnancy. And also the effect of a drug in terms of causing a birth defect depends on timing. And so it's not necessarily starting a drug during pregnancy that puts a woman at risk. It's being on the drug when she gets pregnant at conception that puts a woman at risk. So the limited data suggest most of the drugs are relatively safe. There was a report from Botswana that provided a potential signal of development of a neural tube defect, birth defect, with the use of preconception dolutegravir. There were 4 cases out of 426 preconception exposures, a rate of 0.94%, and this was significantly above the rate seen with other regimens started preconception or other regimens started during pregnancy or in uninfected women, where the rates were about 0.09 to 0.1%. And so where we are right now is in a time of uncertainty. We still need to collect more data to be able to refute or confirm this signal. At the present time, the drug label recommends that you not start this drug in the first trimester. That's probably a little conservative. The neural tube closes by 8 weeks gestation, and so probably use after that time is safe. And it's a good drug. Hopefully by the end of this year we'll have sufficient data to be able to conclude this is real or it's not real. Right, there's been a significant delay in terms of getting any information on drugs in pregnancy after the drug is approved, and there's a mean of 6 years delay from the time a drug is approved and used in the general population, and we even have data about whether that dose is appropriate in pregnancy. And so one way to get that information earlier is to do the pharmacokinetic studies looking at what's the appropriate dose in pregnancy and preliminary safety in pregnancy before the drug is approved rather than waiting until after the drug is approved. And there was a recent large group that gave the government recommendations about studying drugs in pregnancy called the PregLac group, and they sent recommendations to the Department of Health and Human Services recommending that studies in pregnancy be conducted earlier and rather than waiting until the drug is approved and then saying, well, maybe we should study this in pregnancy, trying to study it before the drug is approved. What is non-biased data? So one of the problems with looking at reports of birth defects is that oftentimes you get case reports or you get a report after the birth occurs and there's a defect, and that goes to, say, the FDA or the drug company. You have no denominator there. All you have is, we have a birth defect, we don't know how many women were exposed. So it could be we have 1 birth defect out of 50 exposures, 1 birth defect out of 1,000 exposures. You really need to be able to know both the denominator and the numerator here. And even in a pregnancy in an HIV uninfected woman who's taking no drugs, there is a 3% risk of birth defects. So there is not no risk. There's always a risk when there's a pregnancy, whether or not you're HIV infected or not. And in order to gather data about whether an antiretroviral drug increases the risk, you need to be able to have information that's collected prospectively, that is reported before the woman delivers, and then you follow the woman to find out what's her outcome afterwards, so that you're not biasing the reports to the rare case reports that could occur with or without the drug.